POCUS, the evidence we have for doing POCUS at the bedside. I'm going to provide a brief deep dive into the use of point-of-care ultrasound beyond VEXAS in critical care. And my focus will be on the hemodynamic assessment with cardiac ultrasound and a touch on lung ultrasound. I have no disclosures. And the outline of the talk is to briefly highlight the role of physiological echocardiography in assessment of shock and hypoperfusion, the multimodal integrated approach, some tips and pitfalls along the course of the presentation, the role of the right heart, and I will finish with some take-home messages. And actually, starting with perfusion complements very well to the previous presentation where you were shown the sequence of assessment of hemodynamics, which should always start with assessment of perfusion. And this is a case that highlights my approach. A 55-year-old gentleman who was referred to us from another institution with fever, raised inflammatory markers. He was warm on the edges, sweaty, with worsening markers of organ dysfunction, worsening lactate base deficit. He was also hypoxic and requiring increasing amount of oxygen. And he was hypotensive despite receiving fluid resuscitation in his previous local hospital. And his troponin was only mildly elevated. And you can see here on this focused bedside echocardiogram, parasternal long axis view, that clearly the patient had biventricular impairment. But from this echo itself alone, we cannot precisely assess perfusion because ejection fraction itself as a marker of contractility does not necessarily tell us how perfusion is. And that's why ejection fraction is not in any of the definitions of shock. And ejection fraction can be affected by different hemodynamic parameters. It can be affected by preload, by afterload. It can be affected by heart rate, and it relies on geometrical assumptions. And you have here two examples. That's obviously a transesophageal echo. So the image is upside down compared to the TTE images. You see on your left-hand side a patient with good ejection fraction, but this patient had a profound cardiogenic shock. And the reason here is that, as you can see on color Doppler, that the patient had acute severe mitral regurgitation due to flail of the posterior mitral leaflet. And that's why, despite having normal ejection fraction, the blood was going in the wrong direction. It was going backward into the left atrium instead of going forward through the aortic valve. And another reason for the apparent normal ejection fraction here is that the right ventricular function was severely impaired. As you can see, the RV contractility is much reduced compared to the LV contractility. And that's on itself will reduce the filling of the LV and will cause the appearance of the overestimation of the LV ejection fraction. And these two important pathophysiological contexts make ejection fraction unreliable. And on the right-hand side, you see another patient with poor LV ejection fraction, but this patient had a stable and normal cardiac output and normal hemodynamics. So instead of ejection fraction, in assessing perfusion, we need to use Doppler. And Doppler can be very helpful at the bedside, as was shown to you in the previous presentation. You can estimate the amount of blood, or you can estimate the distance the blood traveled across the LVOT in every cardiac cycle, and that can itself be a way of measuring and estimating cardiac output. VTI is the number we use, which is the velocity time integral, by using pulsed wave Doppler interrogation at the LVOT. And from the LVOT VTI, we can estimate the stroke volume by calculating the LVOT area, assuming that the LVOT is a cylinder. Then you multiply the VTI by the area of the cylinder, which is the LVOT area, and that gives you the stroke volume. If you multiply the stroke volume by heart rate, you get the cardiac output. And if you divide this but by the body surface area, you get the cardiac index. And the normal parameter and the normal range for the LVOT diameter is between 18 to 22 millimeters. And similarly, the same number for the LVOT VTI, which is between roughly 18 to 22 centimeters. But keep in mind that the diameter of the LVOT in the same patient will not change. What will change is the LVOT VTI. And that is the dynamic number that we need to utilize at the bedside to evaluate perfusion. But while we are measuring the LVOT VTI as a marker of perfusion, we have to be careful about several pitfalls, which can make the assessment challenging. If we are aware of the pitfalls, it becomes very reliable in estimating cardiac output. Let's start with the first pitfall, which is one of the basic fundamental principles in Doppler, which is the Doppler angle. The pulsed wave sample volume has to be aligned with the flow of blood across the LVOT, and that's why it is recommended that we start with color Doppler and optimize the view, the apical 5-chamber view, to avoid being off axis. And once we have the alignment, you try to keep the sample volume and the LVOT line as parallel as possible with the blood flow. And you can see here what happens if the angle between the LVOT flow and the pulsed wave sample volume exceeds 20 degrees. You see that the error in measurement doubles from 6 to 13%. We don't in reality measure the angle, but just keep in mind that optimizing the position, especially for those beginning the journey of echocardiography practice, focus on obtaining the best image by aligning the heart with the interventricular septum right in the middle. And that way you are making sure you are aligning yourself with the flow of blood across the LVOT. The second important pitfall is where we measure and where we trace the envelope. The guidelines recommend tracing the modal velocity, which is the brightest, dense part of the envelope. It is, in other words, in other simple terms, defined as the chin and not the beard of the envelope. So you can see here, both are wrong examples of tracing. The one on your left-hand side is overshooting beyond the modal velocity, which gave us a 22 centimeter of VTI. And the one on your right-hand side is also wrong, which is much inside the dense white part of the envelope, which brings us a much different VTI. So you need to provide an adequate tracing, which is just on the dense white part of the envelope, which is the modal velocity. And as you can see here, a slight change in the tracing can provide much different assessment and estimation of VTI, which can consequently lead to wrong conclusions and maybe wrong clinical decision-making. When we use VTI to evaluate perfusion, we have to make sure that there is no abnormal acceleration across the VTI, because if you have clinical situations which causes abnormal acceleration across the VTI, it becomes invalid as a surrogate of cardiac output. And the important example here in critical care is the presence of dynamic acceleration across the LVOT VTI, which can be seen whether with systolic anterior motion of the mitral valve, of the anterior mitral leaflet, which can be seen frequently in hyperdynamic states, especially if you have patient with small left ventricular size, concentric left ventricular hypertrophy after mitral valve surgery with a long anterior mitral leaflet, and also hyperdynamic states due to sepsis, due to anemia, inotropes, tachycardia. All are familiar situations in our critically ill environment. So make sure before you use LVOT VTI across the LVOT to make sure by color Doppler that there is no acceleration, no increase in systolic velocity across the LVOT. And this is what you see if you have abnormal acceleration. Here, the example is with the typical systolic anterior motion of the mitral valve. You see here the anterior leaflet is bowing and bending toward the base of the interventricular septum with systole, which indicates that the flow across the LVOT will be abnormally increased during systole, causing that excessive late acceleration across the LVOT by continuous wave Doppler. And obviously, this causes a state of obstructive physiology and obstructive shock. And despite having high LVOT VTI in these cases, these patients will be hemodynamically unstable, and the physiology will be completely different from cardiogenic shock, because that is an obstructive physiology of shock. And the treatment here changes dramatically. Once you identify obstructive physiology of shock, you have to stop or reduce inotropes. You have to give intravenous fluids to relieve the obstruction by increasing the LV end systolic volume. You have to try to reduce heart rate, whether by beta blockers or pacing, and you have to increase the LV afterload by vasopressors, which is quite different from what we do in pure cardiogenic shock states. But this obstructive physiology is not only possible at the LVOT, it can also happen at the level of the mid cavity of the left ventricle. And as you can see here, this is a short axis. This was a transesophageal echo. And you can see that the left ventricle is hyperdynamic with kissing papillary muscles, with poor right ventricular function, which indicates obstruction at the LV mid cavity, which is confirmed by continuous wave Doppler. You see here that the envelope is showing a lot of gradient in systole, which is exceeding 40 millimeter mercury. And obviously this patient, if you increase inotropes, you will worsen shock, and you might actually cause progressive deterioration of the patient by missing this diagnosis by echocardiography. And I always argue that this is one of the pathophysiologies that is impossible to diagnose without point-of-care echocardiography. And looking back into this obstructive physiology of the LV, this is obviously happening because the LV is thick, so concentric LV hypertrophy, and the patient was vasoplegic with low systemic vascular resistance, but also the right ventricular failure in this patient, which was post-cardiopulmonary bypass, was contributing to the underfilling of the LV and this obstructive physiology. And also remembering that any number we get by point-of-care ultrasound is just a number. The number itself, outside the clinical context, is not that reliable. And here you have examples of a normal number of VTI reflecting abnormal pathophysiology. So a VTI of 20, which is seemingly a number within the reference range, is actually abnormal if you find it in patient with sepsis. Because if you have sepsis, you would expect a much higher VTI. And if you have a VTI of 20 in someone with significant aortic regurgitation, it's also abnormal because patients with moderate to severe aortic regurgitation, they have increased LV end diastolic volume, which usually increases LVOT VTI. And also remember that the equation of stroke volume is not only determined by the VTI, but it's also determined by the area of the LVOT. Remember the equation? LVOT VTI multiplied by the LVOT area. So if you have a patient with a large LVOT diameter or large LVOT area, that can compensate for a small or reduced LVOT VTI, achieving a normal stroke volume. So before jumping into a conclusion of low cardiac output or low perfusion in a patient with low LVOT VTI of 14 or 12, make sure you have a look at the LVOT diameter and measure it and make sure that it's not dilated. And finally, the VTI itself on the left side is not specific to the left heart because isolated right ventricular failure can also reduce the LVOT VTI. Isolated left ventricular failure can reduce LVOT VTI. So VTI is not specific for the chamber being assessed, and that's important specifically if you want to decide for mechanical circulatory support. You want to decide for specific measures to support an individual chamber. And when it comes to specifically identifying the chamber limiting cardiac output, I will only mention this briefly. We need to go back into physiology and try to estimate the cardiac time intervals. You can do that on your left side, on the left heart, by acquiring pulsed wave Doppler between the mitral valve and the LVOT. And then you get the tracing of the filling and the ejection. And then you can measure the isovolumetric relaxation time, which is the time between the aortic valve closure and mitral valve opening, and then also measure the isovolumetric contraction time, which is the time that starts and finishes before ejection. And if you measure both times and combine them, you will get the total isovolumetric time, which in a healthy heart and a good heart should be as minimal as possible. Should be less than 12 seconds per minute. So the longer the total isovolumetric time, the poorer the heart function, and that is very specific for the chamber being assessed. And now we have clear validated parameter for the left-sided total isovolumetric time. So in a patient with cardiogenic shock, if you assess the left heart total isovolumetric time and you find it normal, then you are sure that the problem is specifically in the right heart. And this was validated in this seminal work by Professor Derek Gibson at the Brompton over 20 years ago, who looked at the total isovolumetric time in patients who underwent dilated cardiomyopathy assessment with dobutamine stress testing. And he found the TIVT as a major determinant of cardiac output. And we did that in a patient who had shock after cardiopulmonary bypass, after CABG, redo CABG, and we did pacing optimization using echocardiographic guidance at the bedside. By optimizing the heart rate, we increased the heart rate from DDD 100 to DDD 110, and we also increased the atrioventricular delay from 150 to 240, and you could see in a real time within a few heartbeats that the cardiac output improved and the total isovolumetric time was reduced. But it's not always about the left heart when you assess perfusion. It is fundamental to look at the right heart. And again, pulsed wave Doppler is very useful. It provides valuable insights into right ventricular function, pulmonary vascular resistance, and ventricular arterial coupling. And now when I look at the right heart, I always look at the right heart pathophysiologically and look at the contractility, the preload, and the afterload. This is the afterload, which can be assessed by pulsed wave Doppler by evaluating the acceleration time, which can enable us to measure the mean arterial pressure, mean pulmonary arterial pressure, using this equation, which was validated many years ago. And also the acceleration time itself can give us a clue towards the pulmonary vascular resistance, especially if you see mid-systolic notching in the pulmonary arterial flow. It becomes more reliable in evaluating pulmonary vascular resistance, which is very important in our critically ill patients, because many of the things we do in our critical care environment can increase pulmonary vascular resistance, whether it's mechanical ventilation, acidosis, hypercapnia, atrial arrhythmias, or even fluid overload and overwhelming the right ventricle. And even by looking at the shape of the pulmonary arterial flow by pulsed wave Doppler, you can have important information about survival, as in this paper, which looked at the phenotype of the patient afterload of the right heart, finding that patients who had mid-systolic notching and even patients who had a single spike with a very short acceleration had the worst survival among all patients with pulmonary hypertension. And by looking at this mid-systolic notching and the peak velocity before the notch and after the notch, you can get information about pulmonary arterial compliance and information on the right ventricular performance. And this paper also showed that the peak velocity after the notch provided valuable information on the outcome and mortality for patients with pulmonary hypertension and increased pulmonary vascular resistance. And interestingly, another sign can be seen when you assess right ventricular afterload and hemodynamics is finding a forward flow across the pulmonary valve during atrial contraction, which the pulmonary valve should normally be closed during atrial contraction. And the only situation where the pulmonary valve opens and you find this antegrade flow is when the right ventricular end diastolic pressure is severely elevated. So the right ventricle acts like a balloon. Any atrial contraction will be transmitted into the pulmonary artery, causing this pre-systolic A wave, which was first identified in patients who had correction of tetralogy of Fallot, but now it is very frequently encountered in our critically ill patients, and it provides a clue into evaluating right ventricular hemodynamics and right ventricular afterload. And I will finish by very few cases to show you the importance of echo in assessing hemodynamics in critical care. This was a 45-year-old patient presented to us with suspected ARDS 10 years after having mitral valve replacement for ruptured coat, and using M mode, which is a very simple, probably the earliest utilized modality of echocardiography. There was something interesting here. On M mode, in a patient like this who had left the bundle branch block, normally you should see paradoxical septal motion. But in this patient, there was no paradoxical septal motion. And in this patient with suspected ARDS, we needed to rule out mitral regurgitation because patient was very hypoxic. So the first transthoracic echo, which was done by one of our fellows, did not show any mitral regurgitation, although we have seen this paradoxical reversal of the paradoxical septal motion with the normal motion of the interventricular septum despite left bundle branch block. And that's why we proceeded for transesophageal echo, and the patient had eccentric severe paravalvular regurgitation due to dehiscence of the posterior annulus of the prosthetic mitral valve. That's another example, 48 years old, post-PCI, after a STEMI, patient had clearly low cardiac output with cardiogenic shock, escalating inotropes, and patient was eligible for Impella as a form of left ventricular mechanical support, but we noticed this shadow in the apex of the LV, and if this shadow was a thrombus, this patient will be precluded from having an Impella device. And that's why we did point of care contrast, and the patient had clear, full enhancement of LV cavity, and that's why we were more comfortable proceeding for Impella, and the patient underwent Impella, and few days later, his heart recovered, and he was discharged from ITU without mechanical support. Another example, 25 years old, presented with shortness of breath, few weeks after viral influenza, and the patient has low cardiac output with signs of chronic left ventricular failure with acute on chronic decompensation. So LV dilatation, RV dilatation with mitral regurgitation, pulsed wave Doppler is showing low cardiac output with a VTI of 5. And interestingly, on transmitral Doppler assessment, the patient had no flow in the early phase of diastole. So the patient had suppression of early filling and isolated filling during atrial contraction, which is a marker of severe ventricular dyssynchrony and also a marker of very high left ventricular end diastolic pressure. And when you evaluate perfusion and congestion in these patients, once you identify the A-filler pattern, you must try your best to keep this patient in sinus rhythm because the cardiac output here will be dependent on the atrial kick. So make sure electrolytes are topped up and make sure you try your best to offload the patient to regain the early passive filling of the LV. By using other echo modalities, color M mode and continuous wave Doppler, the patient also had diastolic mitral regurgitation, which confirmed very high left ventricular end diastolic pressure. So the patient underwent Impella and peripheral VE ECMO, the Impella configuration to support the ventricles, but also the Impella to offload the left ventricle. And while the patient was on the Impella and the ECMO, started to become hypoxic, which is abnormal because in patient with Impella, the whole idea is to offload the LV and avoid pulmonary edema. And that's why with bedside echo, we have seen that the Impella device abutted the anterior mitral leaflet, causing a lot of mitral regurgitation, which was causing significant degree of pulmonary edema and fluid overload of the lungs, which required repositioning of the Impella. And finally, the heart-lung interactions, the effect of mechanical ventilation on the heart. Mechanical ventilation is often detrimental for the heart, especially the right heart, by increasing RV afterload, by reducing the RV preload, which consequently often reduces the left ventricular filling. And that's a case where the mechanical ventilation and PEEP caused cor pulmonale by increasing the RV diameter and increase the pulmonary vascular resistance, leading to reduction of RV stroke volume and RVOT VTI. And this patient was developing profound hypoxia and shock from increased PEEP. And that's something we can evaluate by echo, by estimating and evaluating the right ventricular pulmonary arterial coupling, by measuring the TAPSE, which is a longitudinal function of the right ventricle using M mode, and the pulmonary artery systolic pressure, which is measured by the continuous wave Doppler of a tricuspid regurgitant jet. And the normal TAPSE to PA systolic pressure ratio should be more than 0.3. And in this patient, it was quite low. It was 0.2, which indicated uncoupling between the TAPSE and the pulmonary artery systolic pressure. And finally, lung ultrasound is very fundamental, as I highlighted briefly, and also Dr. Cortala showed you. Very important to integrate lung ultrasound in evaluating fluid status and congestion. And now the EACVI published the first consensus document for the use of lung ultrasound to assess patients with acute and chronic heart failure by estimating the degree of congestion and lung water, which is a vital part of fluid assessment at the bedside. And it's not only about fluid, but also about using Doppler in the lungs, which can potentially evaluate hypoxia and shunt. And here we described the blood flow in the lungs and the VQ mismatch, which is potentially a new area for exploring ventilation perfusion mismatching in the lungs using Doppler ultrasound. And that can be done with transthoracic or transesophageal echocardiography, as we are showing here. And finally, VEXIS. VEXIS is very important, as you will hear in the next talks, for showing you the right ventricular preload, which used to be the dark side of the circulation. And because we were taught the Frank-Starling relationship in medical school, which justified administering large volumes of fluid to improve stroke volume, you can see here in this blue curve that while you are augmenting the preload, there will be a point of substantial reduction of venous return. And that's why it is very important to look at when to stop giving fluids rather than focusing on improving stroke volume and cardiac output by giving fluids. And here we described the quantification of the different patterns of flow seen by color Doppler and pulsed wave Doppler. And with this, based on the VEX score, which was validated by the team in Montreal, you can estimate and quantify systemic venous congestion at the bedside using echocardiography and ultrasound. And here you can see the integrated approach put together, cardiac, lung, and even using advanced echocardiographic modalities with lung ultrasound and even strain imaging potentially improve the ability of ultrasound to evaluate different hemodynamic scenarios. And here you see 4 different types of shock evaluating using cardiac ultrasound and lung ultrasound. And that's why we think that echocardiography is not enough in these patients. We have to use the integrated approach, which includes the triangle or pyramid of echo, lung, and systemic venous congestion. And I'm very delighted to see this work finally coming, which was just published a few years ago, or a few days ago, apologies, because 10 years ago, it was unimaginable to talk about advanced point-of-care ultrasound. People had the assumption that point-of-care ultrasound is only a simple assessment performed by people with limited experience. But based on our practice over the last 10, 15 years, we have seen that point-of-care ultrasound can be assessed at the basic, intermediate, or advanced levels. And that's why these American Society of Echo guidelines are very important to define advanced point-of-care ultrasound. And with this philosophy, we had this publication, this textbook, which was published the end of last year, which has the integrated approach put together by a large number of experts from around the world. And finally, my take-home message, I hope I was able to show you that the physiological foundations of hemodynamics are important for echocardiography at the point of care. And the multimodal integrated approach is crucial. Echocardiography is not enough. And assessing fluid status in cardiac ICU should go beyond VEXAS, because VEXAS will not be enough in these patients. And because of the complexity of performing hemodynamic assessments, we need to have and pursue training, and we need to have more available accreditation pathways for a wider array of clinicians evaluating hemodynamics at the bedside. And thank you very much for your attention.